So, good morning. Today we are going to see about neck conditions. First, let's start with cervical spondylosis. This is the cervical vertebra. This is the body. This is the pedicle. And this is the spinous process. That area which connects these two parts, that is known as the pars interarticularis. To be more precise, the articular surfaces and the spinous processes are connected by pars interarticularis. When there is degeneration of pars interarticularis, then it is known as cervical spondylosis. So this can mostly occur because of old age related, and this can result in radicular symptoms too. So how will this knowledge be tested? They will be giving you a question such as, so here is in this x-ray, you can lateral x-ray, you can very obviously see that there is degeneration of this pars interarticularis. So how will the question be asked? They will be telling, Vignet will be having like a patient over 50 has a neck pain, and the MRI shows degenerative changes of the cervical spine. In that case, the diagnosis can be cervical spondylosis. The next condition is the Atlanto Axial subluxation. Atlas is the first vertebra and axis is the second vertebra. When there is a subluxation between these two, the first and the second vertebra, then it is known as the Atlanto Axial subluxation. So mostly this Atlanto Axial subluxation happens in patients with rheumatoid arthritis, and it is a medical emergency. Obviously, we know, obvious, right? So what is the precaution that has to be taken when a patient with rheumatoid arthritis comes for any other surgery? Then CT of the neck or flexion extension x-ray of the neck should be taken prior to surgery, because when a patient will be intubated, they have to rule out atlantoaxial subluxation, and their care has to be given when intubating a patient with rheumatoid arthritis because of this risk. So this is how the knowledge will be tested in the exams. The other aspect is patient with rheumatoid arthritis not undergoing surgery and who has paresthesias of the upper limbs. Now what will you do? Now it is very obvious that the atlantoaxial subluxation has already occurred, and hence the diagnosis is MRI of the cervical spine. Lumbar spinal stenosis. So this is the lumbar spine. So if you see in this is supposed to be this much width and area, but if there is a stenosis of the lumbar spine, then it is known as lumbar spinal stenosis. This is narrowing of the spinal canal. It is common in patients over 50, and it is worse when walking downhill, because when walking downhill the patient has to extend or walk straight, isn't it? They can't bend forward. So in lumbar spinal stenosis, only if they bend forward they will have a relief. But in those conditions like walking downhill where they have to extend and be straight, the stenosis will be more aggravated and the patient will be having more symptoms. I mean, the symptoms will be aggravated. The other one which you should know is they will be having claudication. Neurogenic claudication will be there, but it is different from the cardiovascular claudication. Therefore, the pulses will be normal. So any question which is points toward lumbar spinal stenosis, or if you see a patient who presents with symptoms of claudication and if the pulses are normal, then we can rule out cardiovascular abnormality and focus on this condition. Obesity is also known to increase the risk. So how will the Vignet sound? The Vignet will be pointing towards neurogenic claudication. Like they say the patient will have intermittent claudication, but they will make it very clear that the peripheral pulses are normal and the patient doesn't have cardiovascular disease. Because basically this is obesity only increases the risk, because this is technically osteoarthritic changes of the spine happens, which gets more aggravated when the patient is obese. But obesity is not a mandatory feature. You just have to know that there is a possibility that obesity causes lumbar spinal stenosis. What about cervical foraminal stenosis? This is the foramina, cervical foramina. This is the cervical vertebra, and that foramen through which the cervical nerve jets out is the cervical vertebra. Now when there is narrowing of this nerve exit, That is known as a cervical foraminal stenosis. So this is the foramen that, so when there is a cervical foramen stenosis, then there is loss of sensation, obviously, right? When there's a sensory nerve and that when that is compressed over here, then it results in loss of sensation. There is also and there can also be motor abnormality, like there will be a progressive loss of strength and muscle weakness can be there. Now, since we are focusing about cervical foraminal stenosis, they will be giving you patients like old woman who has difficulty fastening the buttons or weakness of the hand muscles, and there is also loss of sensation of the little finger or else of the hand muscles. Then it directly points towards that there is a sensory abnormality, that there is a motor abnormality of the cervical area, since the involved is a hand muscles. So hence fourth it must be C7 to T1 cervical foraminal stenosis. What is spondylolisthesis? Spondylolisthesis is nothing but when one vertebra compared to the other vertebra, when it comes forward, when there is a forward slippage of one vertebra compared to the adjacent ones, that is known as the spondylolisthesis. So when one is forward to the other, then it kind of resembles a step off. There is a step off sign. This is the key diagnostic features on imaging. So this can either be traumatic or mostly this is idiopathic. There is no reason for spondylolisthesis. What do you understand by disc herniation? If I see here, if this is a cervical vertebra, there is annulus fibrosus and there is nucleus pulposus. Annulus fibrosus is the blue area and nucleus pulposus is the pink area. When there is a tear in the annulus fibrosus and when nucleus pulposus herniates through the annulus fibrosus, affecting the nerve which is exiting through the foramen, then that is known as the disc herniation. This disc is herniated outside. So when this nerve is affected, so it will result in obviously shooting pain because the nerve is affected. And if this happens in the cervical area, then there will be shooting pain along the nerves which supply the hand or the forearm arm muscles. So therefore there will be shooting pain down the arm. So the most important thing that we should know is, usually for exams, preferably USMLE exams, where when there is no sensory abnormality or when there is no motor abnormality, then no diagnostic study is indicated. This is quite shocking to me even initially, but this is how the exam pattern is. I will give you with an example. They will be giving you a vignette where the patient has shooting pain down the arm. And the answer is obviously C8 disc herniation in this case. Now if that is suspected, then the answer should be no diagnostic studies indicated. Even X-ray, even MRI are not indicated. When will an MRI or an X-ray be indicated? When there is real motor or sensory abnormality, not shooting pain. Say for example, there has to be weakness or there has to be numbness. No pain is not considered an indicator for X-ray or the MRI. So for mere radiculopathy, no imaging is necessary. That's what we should know. So this applies, or this goes positive even for disc herniation, even in the lumbar area. Let's say for example, they will be giving you like a straight leg raise test eliciting pain. Suggests disc herniation, isn't it? Yes. But what is the next best step? No further studies are indicated because they are only having a pain and there is no muscular weakness or there is no sensory abnormality or like numbness. So no further studies is indicated. This is the part which goes tricky, but we have to be careful with it. Now what is the treatment? Treatment is NSAIDs and light exercise. Again, the bed rest is a wrong answer. This is another important concept, which is a lumbosacral pain. So here there is paraspinal muscles. So when the paraspinal muscle spasm happens, mostly after lifting heavy objects, then it is the lumbosacral pain. Here what happens is that when you get a patient with pain in the lumbosacral area, then you do a straight leg raise test. When straight leg raise test is done, it is negative. So when a straight leg raise test positive, it is positive only if it produces radiating pain. This will produce pain, but the pain will not be radiating in lumbosacral pain. So the straight leg test, when we do a straight leg test, they will be having pain, but it will not be radiating. So that means the straight leg test is negative and therefore pointing towards lumbosacral pain. For lumbosacral pain, the X-ray is not indicated. Treatment is again NSAIDs and light exercise, and there is no radiculopathy. What is sciatica? Sciatica is the disc herniates in the similar way. As I told you previously, the nucleus pulposus comes out through the annulus fibrosus and the disc herniates, affecting the sciatic nerve, thereby producing a radiating pain. The patient per se can complain of radiating pain, or during the straight leg test, it will reproduce a radiating pain. Now, when there is again for this, we are not going to treat them with bed rest. The treatment is NSAIDs plus light exercise. Meralgia paresthetica. Here there is a lateral femoral cutaneous nerve that gets entrapped. Then the entrapment of the lateral femoral cutaneous nerve is the meralgia paresthetica. Lateral femoral cutaneous, obviously it is supplying the lateral area and the cutaneous. Right, so they will be having lateral thigh symptoms like the pain or paresthesias along the lateral thigh, that is along the outer thigh. Scoliosis. So here scoliosis is nothing but it is the lateral curvature of spine more than 10 degrees. That is what is known as a scoliosis. So for scoliosis, mostly we advocate a brace. Surgery is very rarely indicated, only when the degree of scoliosis is very high. Otherwise, braces can be used. What is kyphosis? Kyphosis is abnormal convex curvature of thoracic spine. So the thoracic spine, instead of being this way, there is an abnormal convex. There is more of convexity in the thoracic spine. So mostly this happens during age. So we can see very old age patients who will be walking with the kyphosis, or it can even happen because of osteoporosis. Sometimes it can even be because of disc diseases. This can result in 30% of the times. So since the lungs are hoarded within this area, it will result in a restrictive lung disease. Cauda equina versus conus medullaris. So here I want you to know that the spinal cord ends at L1, L2. The terminal cone of the spinal cord is the conus medullaris. The nerve fibers that branch from the spinal cord and run inferior to it, that is inferior to the conus medullaris, is known as the cauda equina. That's all. There is nothing. I find the students getting confused with both the conditions. So therefore you should know that the terminal cone of the spinal cord is a conus medullaris. That's why it is called as conus. And the nerve fibers that branch from it is known as the cauda equina. Now both the conditions can cause urinary retention as well as pain in the legs. Now how to differentiate between both the two? Conus medullaris is sudden. So there is a clue, like a cone is very sharp, isn't it? So it is sudden. So the pain is very sudden. This is because all the nerve fibers are all closely packed in the conus medullaris. Therefore, conus medullaris is very sudden and it will result in perianal anesthesia. But whereas cauda equina syndrome is gradual onset and it will result in a saddle anesthesia. These are the two important differences between conus medullaris and cauda equina. With this, we come to the end of our neck conditions. I have just given you an overview. So thank you for listening to me all this while. I have an announcement for you. I am starting my mentoring lessons for medical graduates and USMLE aspirants. If you like my videos and if you want to get mentored by me, I will provide you questions and we can work out with modules. I am going system wise. So each system we can finish it in a speculated time. So if you are interested, you can get back to me by messaging in the comments. Looking forward to see you succeed. Have a good day.